Welcome to Eye Contact. I'm Dan Epstein. Today we are talking to Professor David Spalton about IOL correction of presbyopia. Welcome, Professor Spalton.
Thank you.
IOLs for presbyopia have been around for at least 2 decades, and yet the market penetration is probably less than 10%. How does one explain that?
Well, I think that premium IOLs need premium surgery. So the really important thing with these lenses is that with any of these lenses, you have to hit the biometry emmetropic target, you have to kill the astigmatism. Obviously, the lens has got to be centered and the surgery's got to be really high quality to get those results.
So that you would imply that many surgeons have difficulties with that kind of approach.
Well, not necessarily, but it really does mean attention to a lot of detail to get the biometry right, to get the astigmatism in particular right.
Okay, so precise surgery is a prerequisite.
Yes.
And then comes the question of what do all these terms mean? Multifocal, trifocal, extended depth of focus. The ophthalmologist is confused. He doesn't know the difference.
Well, I think it's got simplified now because really you have monofocal lenses, you have trifocal lenses, or extended depth of focus lenses, really. The bifocal multifocals have gone. I don't really see any indication for them. The trifocal lenses, of course, give you the 3 foci, distance, intermediate, and near. The extended depth of focus are sort of tail of focus. And the difference is that the trifocal multifocals do give you better near vision, but at the expense of more dysphotopsia. Whereas the extended depth of focus lenses give you distance and intermediate vision and reasonable near vision, but the big advantage of much less dysphotopsia.
Fine. What about not having IOLs at all in this connection? People who don't want to have surgery.
Right. Well, there's some really interesting things happening there, Dan. As you know, there's a new drug out which is undergoing a lot of very preliminary trials, which breaks the disulfide bonds in the lens, and the lens then becomes more flexible. And there's some early clinical work which shows that this can, I don't know about restore, but it certainly improves accommodation in the young presbyopic patient. Really interesting work, but it needs an awful lot more development to see quite where that's going.
It's not at a clinic stage.
No, we had a discussion, a presentation on it yesterday in the Blue Sky Lens Research Symposium. It's really interesting, but we need to wait and see. It's a long time before we know.
If we return to IOLs, what is the difference between monovision and mini monovision?
I think mini monovision is a difference of 1/2 to 3/4 of a diopter between the emmetropic eye and the near focus eye.
A normal monovision? Where would you put that?
Well, normal monovision is 1.5 diopters, really. I think once you get more than 1.5 diopters disparity between the 2 eyes, people then lose a lot of stereopsis.
Now, the major motive for having presbyopia correction with IOLs is to be spectacle-free.
Yes.
Do you have any numbers in your head on how many people become spectacle-free after such implantation?
Oh, I think a lot of them do, as long as you get things right at the start of surgery. But with the extended depth of focus lenses, I tell patients that they will need to wear readers for near vision. It's the old story of under-promise what you're going to do. And with it, I find my own experience with the extended depth of focus lenses is that their reading depends very much on the light that they're in. So if someone's in a really good bright light, they can read often very happily. Poor light, they find it more difficult. So that is a point. But they will have good computer vision and that sort of thing without spectacles.
On the other hand, there are people who are presbyopic and can read well in good light, as contrasting poor light.
Absolutely.
So that is still even applicable to the natural lens.
Yes.
Yeah.
I know, Dan, that when I'm on the beach on a bright sunny holiday, I can read pretty well without my spectacles.
Beautiful. Where do you see the future? What else can be improved to increase that less than 10% penetration?
Well, I think there's some really interesting things. The technology is really moving on pretty rapidly. different types of extended depth of focus lenses coming out. We have the SIFI mini-well lens, which works on asphericity. I've never not used it myself, but the results when you speak to people are very good with it. The other interesting lens is the pinhole lens, the IC8, with a small pinhole aperture which you put in the non-dominant eye, leaving the other eye with a monofocal lens. That has some advantages in that because it's a pinhole, it's very tolerant of astigmatism. Yeah. So that's interesting. And then there's a whole batch. Every company is bringing out an extended depth of focus lens. Some really innovative, interesting ideas out there.
On the pharmacological front, do you see anything else coming?
No, there was, well, not in the near future, I think. I mean, there are drugs and compounds out there. There's a drug called lanosterol, which has been shown in animals to actually improve nuclear cataracts, which is amazing. So that's you know, quite a long way away, I think. And the other thing, in the Blue Sky Lens Research Symposium we had yesterday, we had a fascinating talk on stem cells and regeneration of the lens in children, which seems to be possible. I mean, it's almost science fiction, really.
Is that from San Diego?
Yes, yes, yes. Be interesting to see. I mean, once again, enormous amount of work. But I think in some ways we're seeing some really new, interesting developments in lens replacement surgery there.
And industry seems to be interested in investing.
I would think so. I just don't know. But I mean, a lot of these things will be 5, 10 or more years before they come into clinical practice. So the lead-in time is obviously going to be massive in some of these things.
But still, it sounds promising.
Yeah, very interesting. Very interesting. I think the interesting thing is we're probably just starting to see some ideas about the medical treatment of cataract rather than cataract surgery, which would be devastating for all of us.
Quite. Thank you for joining us. For more information on this and related topics, please visit us on eurotimes.org.